to Dr. Marion Peters, who is a professor of medicine and hepatology at the University of California, San Francisco, a frequent panelist here with us. She's in the process of sharing her screen right now, which is great. And she's going to talk to us about liver disease and HIV infection, which I'm sure she will talk about hepatitis viruses as she goes. So, Dr. Peters, it's great to have you with us. We'll turn it over to you.
Thanks very much, Mike, and thank you for inviting me to talk about liver disease and HIV. These are my advisors, mainly for HBV. And the learning objectives are really to talk about the most common causes of liver disease in people living with HIV, to determine how to evaluate abnormal liver tests, and to discuss new issues in the big three, Hep B, Hep C, and fatty liver. So when we think about liver disease in patients living with HIV, the most common diseases are viral hepatitis, but also fatty liver disease, and patients can get liver diseases that any patient gets. They can also get drug-related hepatotoxicity for antiretrovirals. HIV itself has an effect on the liver, and patients can have problems with alcohol, drugs, and medications. I think it's absolutely critical to remember that patients are not just taking antiretrovirals, but they can have toxicity from antituberculous therapy, antifungals or antibacterials. NSAIDs can cause liver disease. Neuropsychiatric medications can cause liver disease. And over-the-counter herbs and spices can cause liver disease. So it's really important to get a full history of not just prescribed medications, but over-the-counters, herbs, and bodybuilding supplements, all of which have been associated with acute and chronic liver disease. So the initial evaluation is, of course, the history and physical, but the liver test to assess liver function, it's albumin, bilirubin, and INR. To assess cholestasis, that's alkaline phosphatase and bilirubin. Inflammation or cell death is assessed by AST and ALT. No, they don't assess liver function, they assess cell death. And if you want to know if a patient has portal hypertension, that's low platelets and low white count. The common liver disease, as you've just heard for hepatitis B, you need surface antigen and antibody to core and surface. For hepatitis C, you need HCV antibody and HCV RNA in a patient who's had hepatitis C in the past. For fatty liver, you need fasting glucose, triglyceride, cholesterol, and hemoglobin A1C. You need to assess alcohol and, of course, drugs. Less common liver diseases include metabolic syndromes such as hemochromatosis and Wilson's, or autoimmune disease, or alpha-1 antitrypsin deficiency. These can occur in patients with HIV. Therefore, if you don't find a cause, you need to assess these. All patients, as you just heard, should be vaccinated to hepatitis A and B. And I always recommend liver imaging for your initial evaluation of abnormal liver tests and fibrosis assessment. In the bottom right, you can see fibrosis assessment can be done with APRI and FIB4, which can easily be obtained through calculators on the internet, or a FibroScan, or an ultrasound with an AFI attachment. Rarely liver biopsy is needed, and imaging is only helpful for fibrosis if there is portal hypertension. So let's start with hepatitis.
Dr. Peters, this is Mike Sag. So I think something's gone a little bit awry. You might want to reshare your screen and then go to live presentation, because I don't think it's coming across. So do you mind doing?
Oh dear, what do I do?
Just hit presentation, hit the presentation mode in PowerPoint. I think that should fix it. At the bottom there.
Everyone, I wonder, we've not seen Dr. Peters' slides through the beginning of the presentation. If it's not too much of an imposition, perhaps we can start over, Marion? Would that be possible?
Oh dear. So I did slideshow start. You are screen sharing.
Go to the bottom right, and there's like a little icon for like a projector down there in the bottom right. Yep. Come on down further down. Yeah, you sit right, go right there. Yes. Click that.
Can you see anything? Resume share. Hang on. Sharing is paused. I can't get to my other computer.
Okay, sorry about this. So yeah, this is live television. This is what happens. Okay, so maybe I would just say what I would do is unshare your screen if you can.
Stop share.
Okay, perfect. And now set up your slides for presentation view. And then, yeah, and then reshare, and that should work.
It says I'm screen sharing.
Yeah.
But you can't see it.
Well, we're
Dr.
seeing,
Peters, can you hit the swap displays button? In your presenter view, there should be a button that says swap displays.
Yeah.
Swap displays.
Hey, there we go.
There you go.
Now
Oh
we're there.
my God.
So let's restart the timer. I'm sorry, if you don't mind starting over, you have to repeat yourself, but this is it. So we're good. Thank you.
I really apologize. You can have to look up my conflicts of interest. I'm going to talk about common causes of liver disease, how to evaluate them, and focus on hepatitis B, C, and fatty liver. So we talk about liver disease. The big ones are hepatitis C, hepatitis B, and fatty liver disease, but you can get other causes of liver disease, and I'll talk about that. HIV can affect the liver, and antiretrovirals can cause drug toxicity. In addition, alcohol, drugs, and medications can add or be the cause of abnormal liver tests. So when you take a history, think of not just the antiretrovirals, but drugs for TB, fungi, and bacteria. NSAIDs can cause toxicity, neuropsychiatric medicines, and over-the-counters. It's really important to ask about herbs and spices and bodybuilding supplements, as these can cause hepatotoxicity. And when you get inflammation and stellate cell activation, you then can get fibrosis, which can lead to cirrhosis. So when we talk about evaluating abnormal liver tests, first the history and the physical, but then the tests you require. For liver function, albumin, bilirubin, and INR are tests of liver function. AST and ALT are tests of inflammation, not function. They assess cell death. Cholestasis, alkaline phosphatase, and bilirubin. And if you are concerned the patient has cirrhosis and portal hypertension, that's assessed with low platelets and low white count. The common diseases, if you just heard, for hepatitis B, surface antigen and antibody to surface and core. For hepatitis C, antibody to core and HCV RNA. For fatty liver disease, fasting glucose, triglyceride, cholesterol, and hemoglobin A1C. The less common causes of abnormal liver tests can occur in patients with HIV, such as metabolic syndrome, hemochromatosis, Wilson's, autoimmune diseases, and alpha-1 antitrypsin deficiency. All patients should be vaccinated to hepatitis A and B, as you heard in the last talk. And I always recommend liver imaging for the initial assessment of patients with abnormal liver tests, plus fibrosis assessment. And the bottom right shows the fibrosis assessment. APRI, AST to platelet ratio, or FIB4, are easily obtained on the internet with calculators. a FibroScan if it's available, or an ultrasound with a fibrosis assessment tool added called the ARFI. Liver biopsies are rarely needed, except if you're looking for the less common causes or to assess non-alcoholic steatohepatitis. And imaging is not good for fibrosis. It only is good if a patient has portal hypertension. So let's move to hepatitis B. There are worse outcomes with HIV and Hep B co-infection. When you compare HIV and hepatitis B to hepatitis B monoinfection, there's a higher percentage of E antigen positivity. There's a lower loss of surface antigen after acute infection. So after acute infection in adults, the vast majority of non-HIV infected individuals lose surface antigen. But after acute hepatitis B in patients with HIV, 21% maintain surface antigen. So they have a higher risk of chronic infection. They also have higher HPV DNA levels, longer duration of viremia, lower aminotransferase levels, and more rapid progression to cirrhosis. On the right, comparing HIV Hep B to HIV alone, there's a 14-fold higher liver-related mortality and a higher risk of progressing to AIDS and death. And co-infection is still a problem in this decade, even in the era of tenofovir and TAF. This is a nationwide inpatient sample of 72,000 Hep B patients, 133,000 HIV, and over 8,000 co-infected. And compared to HIV mono-infected, there were higher liver-related admissions in the co-infected, 48% versus 28% in the mono-infected. And compared to HBV mono-infection, co-infected had higher liver-related mortality, higher all-cause mortality, and a longer length of stay. So it's worse for the hepatitis B and it's worse for the HIV. You all know this data, that antiretroviral agents should include activity against both HIV and hepatitis B as treatment for all patients co-infected with HIV and hepatitis B, regardless of CD4 count and regardless of the need for treatment. Antiretrovirals must include 2 drugs active against Hep B, preferably tenofovir and FTC, regardless of the level of HPV DNA, because such a regimen will reduce the likelihood of immune reconstitution syndrome against B and reduce the risk of resistance that can occur with newer regimens without HPV active drugs or with 3TC or FTC alone. So 2 B drugs as part of ART. In monoinfection, current therapies are really terrible at inducing loss of surface antigen, under 10%. There has been no new class of Hep B drug since 1990 to 1988, which will come as a shock to you guys who heard all about these new drugs yesterday for HIV. So we need new drugs, and I'll talk a little bit about that in the breakout. However, with co-infected patients, after initiation of ART, there can be loss of surface antigen, and that's higher than we see in mono-infected. These are 2 studies from Croy last year showing from the Zambia 10% loss and from Germany 18% at 2 and 4 years respectively. And it's not clear if these individuals had adult-acquired hepatitis B, so they had chronic infection and initiating heart just tipped them over to losing it, because perinatal infection, where the vast majority of people become chronic, it's less likely to occur. However, this had been shown by Gail Matthews in 2013, and this is a very informative slide showing in red at the top individuals who lost surface antigen, and green at the bottom individuals red at the top, individuals who did not lose surface antigen. And you can see their quantitative surface didn't change. But in green, you see that individuals who subsequently lost surface antigen had a rapid drop in quantitative surface over the first 40 weeks. So these are the ones who went on to lose surface antigen. What about antiretroviral as HBV PrEP? And this is a nice study showing Hep B free survival in MSM. There are over 2,000 individuals tested for hepatitis B immunity and vaccinated, but 381 of them failed vaccination. There were 33 incident HPV infections, and you can see that if you're looking at a cumulative HPV survival on the graph, those without hepatitis B, the highest and best outcome was with HPV active treatment, including tenofovir. In red is HPV active treatment without tenofovir, and in gray at the bottom are individuals with no treatment. So if you include tenofovir in ART, it can act as PrEP in individuals who failed Hep B vaccination. So in summary, HIV increases HBV chronicity after acute infection. It increases antiretroviral-related hepatotoxicity. It increases the risk of end-stage liver disease compared to hepatitis B alone. Tenofovir-based therapy can be HBV PrEP. And importantly, ART can lead to loss of surface antigen, especially after the first 2 years of initiation. You should screen all Hep B patients for cancer, not just those with severe fibrosis. So this is different than other causes of liver disease. You can get cancer, liver cancer in Hep B with any stage of fibrosis. There are new drugs on the horizon, and reactivation can occur with immune suppression, and I'll talk about that in the breakout. Turning to hepatitis C, DAAs are highly effective, and treatment is the same regardless of HIV, with minor exceptions. But drug-drug interactions are greater, especially with NS3 protease inhibitor-containing regimens. Tenofovir regimens appear safe with sofosbuvir. Switch of ARVs prior to DA therapy is safe and effective, but you need to check for stability. Early treatment of acute HCV is successful and at the moment is the same as for chronic. Reinfection can occur, and HBV cure improves survival, liver, AIDS-related and all-cause, as well as renal disease and diabetes. So let's look at some of that data. This is data from the Gaseta cohort in Spain. On the left in A, you can see overall mortality survival is better in those with SVR than those who did not get cured. And on the right, liver-related death didn't occur in those with SVR compared to those with no SVR. And they also showed lower AIDS-defining conditions, lower non-liver-related deaths, and lower non-liver-related, non-AIDS-related deaths. They subsequently had a 5-year follow-up of these patients and showed that cure of hepatitis C was associated with a significant decrease in diabetes and decline in chronic renal disease, really highlighting that chronic hepatitis C is a systemic inflammation. And if you get rid of the systemic inflammation, you do more than just improve the liver. But you don't avoid the possibility of liver cancer post-SVR. This is in mono-infected VA patients, 33,000 of whom a third were cured. There were 100 new HCC cases. The incidence rate of cancer in those without SVR was 1.32% per year, those with SVR 0.33, and the highest risk was cirrhosis at the time of cure. Second was being old. It's always bad to be old, as you heard, and even over 55 was a significant risk. Hispanics had a higher risk. There was a higher risk in diabetics and those with alcohol abuse. An important point, liver cancer can occur after cure of SVR, but it's mainly in the cirrhotics. So you need to assess what the patient has before you start treatment so you know how to follow them after treatment. If they have low or no fibrosis, they don't need monitoring. If they have advanced cirrhosis or advanced liver disease, they need long-term follow-up and surveillance for HCV and varices. And if they're intermediate, they need to be monitored for progression to advanced fibrosis. This is a couple of important points about incident infection. On the left, this is a French study looking at HIV-infected MSMs, and you can see that the risk of acute HIV occurring, incident infection, has been increasing over the decade, way more in MSM than other risk groups. On the right is a beautiful study as treatment as prevention from the Netherlands, where they introduced unrestricted access to HCV therapy in 2014. And you can see in blue that the incident infections of acute HCV decreased dramatically by allowing treatment for all. So treatment as prevention. Another important point is Hep C antibody is not protective. So reinfection can occur. In Germany, in the GECKO study, it was 9 per 100 patient years in MSM and compared to 1 in PWIDs. In Madrid, it was 6 per 100 patient years in MSMs, and a recent study from Canada was 3 per 100 patient years in active PWIDs. Second important point is spontaneous clearance after acute Hep C is lower in patients with HIV. So you see the graph on the right from the PROBE study from Europe, that spontaneous clearance occurred in 11%, way lower than in HIV negative patients. And the last point I want to make is even after cure, you can have other liver disease. This is a very nice study from Susanna Nagy and Mark Sulkowski of 275 patients who were co-infected or HCV mono-infected. Greater than 95% of them had a liver biopsy prior to treatment, and after SVR, abnormal liver tests were seen in about 12% overall, but 20% of HIV patients. And the risk factors were HIV, antiretroviral, steatosis, alcohol, statin use, and severe fibrosis or cirrhosis, that you can go on to get abnormal liver tests. So there are many benefits of HCV cure, liver and non-liver, decreasing systemic inflammation. It's important that those with severe fibrosis or cirrhosis need HCV monitoring post-SVR and with imaging and alpha-fetoprotein every 6 months. You need to stage fibrosis pre-treatment to know how to monitor the patient post-cure, because we don't have a good way of assessing fibrosis post-cure except liver biopsy, which is not very popular. FibroScan is no good. Concurrent alcohol or fatty liver places patients at risk for future cirrhosis, so they need to be monitored for fibrosis progression, and FibroScan is good for monitoring fibrosis progression, not regression. Need to counsel healthy liver practices for all with alcohol, drugs, diet, lifestyle, assess metabolic syndrome, and importantly, monitor for reinfection. Reinfection has to be discussed, with all patients, but especially at-risk patients. What about NAFLD, the last big topic, which is fat or steatohepatitis, non-alcoholic steatohepatitis, NASH, which is fat and inflammation with and without fibrosis. can go on to cirrhosis and hepatocellular carcinoma. In the general population in the US, 30% of the US population has NAFLD and 2 to 5% has NASH. However, in the obese population, which is a third of America, fatty liver is in 60% and 35% have NASH. And in those with type 2 diabetes, NAFLD is seen in 75% and NASH in 50%. When we think of the metabolic syndrome, you heard about this earlier today, obesity, central adiposity, insulin resistance, hypertriglyceridemia, hypertension. NAFLD is the hepatic manifestation of the metabolic syndrome. It's higher in Hispanics. There are hereditary and genetic associations with polycystic ovarian syndrome. I'll talk about HIV and also with sleep apnea and hypothyroidism. This slide compares primary NAFLD in the non-HIV in the middle and HIV associated on the right. The prevalence is about 30%, as I told you, but varies by study. And in HIV, there are a number of studies in meta-analysis that shows it's around 35%. There's a recent study from Canada in a large population saying it was 50%. The risk factors are the same: obesity, type 2 diabetes, dyslipidemia, metabolic syndrome, hereditary, genetic. But in addition, NAFLD can occur at a lower BMI in HIV patients, so-called lean NASH. There are HIV-specific issues such as older NRTIs, D drugs, early generation PIs, and lipodystrophy, and perhaps with integrase inhibitors, but we need more data on that. NASH prevalence, that is inflammation and fat, is about 25 to 30% of NAFLD patients who receive liver biopsy, and it certainly appears higher in studies of HIV patients, 45, 42% of patients who had a liver biopsy. Fibrosis progression is in patients with NASH, 1 stage in 7 years in primary NAFLD, and appears to be faster in a tiny study performed recently, so we need more data on that in HIV. The long-term outcome is increased cardiovascular risk, increased liver-related and all-cause mortality, and certainly in HIV, there's increased cardiovascular disease, but other long-term outcomes are not clear. So how do we manage patients? First, lifestyle changes, diet and exercise. Losing fat improves steatosis, losing weight improves steatosis, improves inflammation, and even improves fibrosis. Bariatric surgery in the non-HIV has resolved NASH in about 85%, and fibrosis has decreased in 1/3. Cardiovascular disease is the #1 cause of death in patients with fatty liver. And 25% of major cardiovascular events, these patients have NAFLD. So treat the metabolic syndrome, hypertension, dyslipidemia, and diabetes. Metformin and simvastatin are safe in liver disease and should be used if indicated, and they have a potential benefit for HCC chemoprevention, but decreasing progression of fibrosis is the #1 way of decreasing hepatocellular carcinoma risk. Targeting NASH specifically, vitamin E has been shown to be of benefit, but not in diabetics or those with cirrhosis. Pioglitazone is beneficial, but has a side effect of weight gain. And there are a number of trials, including tesamorelin, FXR agonists, CCR25 antagonists, and agonists to PPAR, FGF, and GLP-1. So this is an exciting area that will be exploding soon, including in HIV. So NAFLD is an umbrella term that includes fat and non-alcoholic steatohepatitis. Biopsy is needed at present to diagnose NASH. It's higher in patients with HIV. Steatogenic and fibrotic effects of HIV and ART likely impact the natural history. It has a higher prevalence of lean NAFLD, so you may not have obesity. The prevalence is likely to increase with the aging HIV population. The main risk factors are metabolic, genetic, and hereditary. The leading cause of death is coronary artery disease. It's an important contributor to cancer and will be the #1 cause for liver transplant in 2022. And management hinges on weight loss, exercise, avoid carbohydrates, and metabolic syndrome control. One slide on hepatocellular carcinoma, because there's an increased prevalence with increasing lifespan. You need to treat. The treatment of viral hepatitis decreases fibrosis and cirrhosis, but cancer can occur after HCV cure. It occurs in younger patients with HIV, and whether survival is worse is not quite clear at the time. So it's essential to diagnose cirrhosis, screen all cirrhotics and all Hep B patients. Screening and early diagnosis is critical for access to local regional therapy and liver transplant. So in summary, there's a lot of liver disease in HIV. HCV can be treated but can recur. There are new drugs for Hep B. NAFLD is the major disaster with us now, requiring diagnosis and management. And while viral hepatitis, alcohol, and fatty liver are the most common, abnormal LFTs should be evaluated as in HIV negative individuals. There's less hepatotoxicity with newer ART, but with longer lifespan, there'll be increasing morbidity and mortality from liver disease and increasing hepatocellular carcinoma. So we need to determine the amount of fibrosis. Thank you.
Fabulous, fabulous, Marion. Just always a great presentation. I'll kick off the questions while we're waiting for them to appear. I have two, really. One that carries over from Dr. Spock's presentation, and that is, if we have the person who's core antibody only, just that's it, and you see no surface antigen, no DNA, do those folks also need Q6-month screening for HCC?
So it's a good question. I'm going to talk a little bit about this in the breakout, but patients who are core antigen positive, in the old days, they could be false positives. That's very rare now. With HIV, it's possible they could have occult hepatitis B, but in the ACTG and the Ys, that was 2 and 10%, so very low risk. And those patients need to be followed, but the vast majority of them won't have ongoing liver disease. But I'm going to present a case that does.
Okay. And then the second thing that you really nicely covered, acute hepatitis C, that we see, especially among MSM who are in our patient population. One of the things that has changed in the hepatitis C guidelines back and forth, but is whether or not to treat acute hepatitis C with DAAs. And initially we said no, and now I think it's a pretty strong and resounding yes. Treat them. Even your spontaneous reversal data underscored that, but it also was an epidemiologic reason to prevent spread. Could you talk about that a little bit?
Yes, so the slide that showed, first of all, spontaneous clearance is very low. So the recommendation now is to treat when you diagnose. And the second that I didn't put in the slide because I didn't have enough time, it's very clear that treatment is prevention. And there have been some beautiful modeling studies showing that if you have a DAA success in the high 90s and the cost has continually come down, that it's cost effective to treat as prevention. And the Dutch study, which I did show you, showed you very nicely that treatment is prevention in the high-risk MSM population.
Yeah, absolutely. I just wanted to underscore that. Okay, so here we go to some questions. What about FibroSure for non-HCV related fibrosis assessment?
You can use FibroSure. You pay for that. and it isn't better than Fib4 and APRI.
So
So if
cheap.
you're going to spend some money, you should use ELF.
Okay. Can you elaborate on why imaging is only useful in the setting of portal hypertension?
Great question. We published a paper on this a couple of years ago showing that diagnosis of cirrhosis on ultrasound can be inaccurate. And we found that a quarter of patients when we wrote Hep C or hepatitis B in the diagnosis, they diagnosed cirrhosis. I went on to biopsy the patient because it's a critical thing, and they had F0 or 1. So they were wrong. And if you have ascites, splenomegaly, varices, of course you have cirrhosis. But a shrunken liver can be caused of acute disease. And a nodular liver is really not a great way of assessing cirrhosis. Now, if you have something that looks like a bunch of grapes, that's cirrhosis. I'll accept that. But don't believe it's cirrhosis just on an ultrasound shape of the liver, because ultrasonographers will overinterpret.
A liver that looks like grapes will be a staphylococcal liver, I guess.
Yeah.
So big movement in my community is for herbal medicine, and I suspect that means beyond cannabis. What are the most common herbs and spices and things that cause hepatitis?
So it's actually a long list. St. John's wort, of course, is the one that comes up because it's frequently used. The best way of looking is livertox.gov. It's a beautiful website from the NIH, from Hufnagel, where they actually put in every single, you can put in the name of the herb, the spice, and they will give you the data. So it's actually very good to get assessment. And normal, the old idea of enough's enough and too much is terrific is not true. Excessive anything can lead to, many drugs in excess can lead to toxicity.
Okay. For the patients who have a high HBV DNA despite being on tenofovir and FTC, is there any advantage to adding another anti-HBV drug like entecavir?
So it's a great question, and I didn't put in that data, but I did put it in my summary, that a very nice study from, I think it was also from Susanna Nagy last year at Croy, and Jennifer Kaiser, they looked at patients who were on antiretrovirals, including tenofovir, and co-infected. And when they came into their clinic visit, their HIV was undetectable, but they had detectable HPV DNA. And they were able to use dry spots, and don't ask me to explain it all, but they could assess that they could assess whether it was short-term stability or long-term stability, and found that the patients were taking their drugs recently, not long-term. And for hepatitis B, you need longer time on therapy to get a better outcome. And their summary, and 2 papers were presented on this, were that actually people who had detectable DNA were actually being non-adherent. Now, we also have data that we did about a decade ago, and Lampertico did in Italy, showing that if you add entecavir, you can drive down the DNA, but it didn't affect the outcome.
Okay. Here's a question about using dolutegravir 3TC only in a patient with HBV and a loss of surface antigen. What do you think about using 3TC, in essence, monotherapy for HBV?
I don't like it.
Yeah.
I don't like it because if they've lost surface antigen, they can reactivate with, if they get lymphoma and need rituximab. So if they didn't have any problem or any issue, but if something changes in their immune response, and they can develop resistance.
Yeah. So just quickly, the resistance occurs at about 18 to 20 weeks of lamivudine monotherapy. And what's fascinating, it's the same motif, the YMDD motif that occurs on HBV that also leads to resistance with HIV at the 184 position. We talked about fibrosis scores. It's generally a good thing if you're suspecting liver disease overall. I think I can skip that one. But given the high risk of HBV and MSM, are they better treated with tenofovir versus non-tenofovir? In other words, the PrEP kind of concept here. So let's say if you have MSM, they're not HBV infected, you vaccinated them. Are you compelled to also use tenofovir here?
Well, if they responded to vaccination, no. But if they didn't respond to vaccination, it's a small study, the Dutch study, but it did suggest that if you put them on a tenofovir-based regimen and they're at risk, then you've protected them.
Right.
Not 100%, but much more than no tenofovir.
If you have a patient you check a fibrosis sort of screening test and it's F2, how often should you repeat that assessment to see if they're progressing? And it might be from NASH or something.
So if they're F2, and this is if you have done this before HCV treatment, and they're cured and their ALT goes down to 14 and they don't have hypertension, diabetes, hyperlipidemia, you just monitor their liver tests. They don't need ultrasound screening. But if they're F2 and they have the metabolic syndrome, hypertension, dyslipidemia, steatosis, and abnormal LFTs, you need to monitor that patient as you would any patient with fatty liver.
Yeah.
There are reports of cancer in F2 in fatty liver, but there are reports, it can happen, but I think you need to monitor the patient as you would any liver patient.
So we got one more question. There's a couple questions about hepatitis C, and you made it very clear that if somebody's F3, F4 pre-treatment and you cure them, you still want to follow along for the development of HCC. Two quick questions. One, if they're F2, can you just forget about it at that point once they're cured for HCC and no other factors?
No, it's exactly the same answer as I gave before. If they're F2, you need to monitor them for progression, which you can use a FibroScan. And for regression, it's very hard. You can't use a FibroScan because it's not accurate.
No, I meant for screening for hepatocellular carcinoma.
So you would screen them if they progress to F3, F4.
Right.
Sorry.
Okay. What if they go the other way? What if you had F3?
If you can prove they go the other way, you can stop monitoring them. Stop following them for liver disease.
Perfect. Wonderful. And I know a lot of the folks who are heading to your breakout are looking forward to the comments that you alluded to. I mean, it's a very important topic area, and I know that folks will benefit from your breakout. And thank you. It was a wonderful lecture. And